Colegas, muy buenos días. Bienvenidos y bienvenidas a la sesión de hoy. Mi nombre es Natalia Houghton. Yo soy
Colleagues,
especialista
good morning. Welcome to today's session. My name is Natalia Houghton. I'm a specialist for monitoring, assessment, and analysis of healthcare systems for PAHO WHO. And during these next 2 hours, I'll have the pleasure of hosting you as moderator for this virtual seminar. This is the first webinar on a new series on primary healthcare, a new proposal which resumes experience on the series on policy options and resilience that we organized in 2022. For this first event, we have decided to tackle a very central point to PAHO in the development of healthcare systems, such as accessing healthcare services, overcoming barriers, and guaranteeing continuity. Apologies, the audio is cutting out. We have the pleasure to have a group of distinguished panelists, guests who have accepted this proposal and this exchange that we will hold next, and that will have the chance to present. Before beginning, I would like to address some housekeeping. Apologies, the audio is cutting out. If you need to connect, if we could have access to Dr. Jarvis, please. As we resolve Dr. Jarvis' connection, I'd like to tell you that we're offering simultaneous interpretation in the 4 official languages of the organization, being English, Spanish, Portuguese, and French. Please feel free to select the appropriate language to your convenience. To do so, select the language. You may select the button or icon in the globe icon in the lower part of your Zoom screen. We also have simultaneous interpretation in international sign language that you can see throughout the presentations, and interventions are part of the panelists. This on effective access to healthcare systems. I hope that you notice that you can send your remarks at any point of the seminar via the chat and your questions via the Q&A section, which is also on the lower part of your screen. Lastly, we remind you, especially to our panelists and from the organization, that you should keep your microphones off to facilitate the development of our activity. Please let me know if Dr. Yarbas has now been able to connect.
Dr. Jarva nos está indicando, colegas, que está.
Dr. Jarva is telling us that he's trying to connect, but still he has not been given entry to the webinar room. Colleagues, if you allow us just a few minutes, please, as we are able to ensure the connection of our director, Dr. Jarbas, who will be with us in this webinar, providing us some opening words and providing an explanation on what this seminar, today's seminar entails. Just a few minutes, please.
Bien, colegas, asegurarle que detrás de pantalla están nuestros colegas también acompañando en la organización de
Behind
este
the
seminario.
scenes, we also have our colleagues trying to resolve Dr. Jarbas Barbosas's connection, who will be providing us some opening words. Now, in the meantime, just to remind you that you may select the language of your preference using the icon on the lower part of your screen in the shape of a globe. And also throughout the seminar, you will see via the chat that our organizers will also be presenting forwarding key documents and instructions for that will be made available to all participants. Just a few minutes, please, colleagues.
Colegas, el doctor Jarbas nos avisa que ya está en la sala.
Colleagues, Dr. Jarbas is telling us that he is now in the room connecting via the new link. However, we must give him access for him to access the room. In the meantime, as we resolve this technology issue, which, as you know, always occurs during these virtual seminars, if you allow me, I will take this chance to begin presenting those who will be our expert panelists. And we are actually honored to have them, such a select group of participants, as we're able to resolve connecting with Mr. Jarbas Barbosa. First, we will have Dr. Ernesto Bascolo. Dr. Bascolo is the chief of the Primary Healthcare Attention Unit and Holistic Provision of Services, PAHO. He's an economist, a doctor in social sciences, and has a PhD in governance and healthcare systems, with more than 30 years experience combined nationally and internationally in teaching, research, and management of healthcare systems, as well as healthcare policies, and who has prepared today a very important presentation which deploys two regional reports from the organization on this issue of effective access to healthcare systems. We also have the expertise and participation of Professor Bruce Shader, founding member and president of the Working Group on Rural Practices of the World Organization of Primary Care Physicians, mostly known as WONCA. He's a rural chief physician and main doctor for remote and rural medicine in Queensland University, Australia, and has actively contributed in every declaration, document, and strategy produced during the last 3 decades on part of the WONCA organization. He has always been accoladed with the Medal of the Order of Australia for his service to rural medicine and to his rural community of Theodore in Australia. Also with us, Dr. Myrna Cunningham, former chair of the UN Nations Permanent Forum on Indigenous Issues. Dr. Cunningham is a physician, surgeon, misquit, feminist, and indigenous activist from Nicaragua who has participated in political and social processes relating to the struggles for the women's rights and indigenous peoples in Latin America. Dr. Cunningham is recipient of the Heroine of Public Health accolade from the organization. He has received an honorific accolade from the University of Mexico and also been coordinator for the Indigenous Lecture from the Indigenous Cultural University. Also with us, our dear colleague, Dr. Sergio Minoy, international consultant of PAHO. He's currently a physician, a specialist in family medicine and community medicine, and doctor on healthcare economy, and until recently, a professor of the sanitation systems from the Andalusian Public Healthcare School, where he has provided much input to reflection, implementation, and development of APS in the international scope or domain, with a professional career extending 35 years and more than 1,000 articles published on this such important topics such as APS. We also have the pleasure to have our colleague from the World Health Organization, Dr. Diparajan. She's works at the main primary healthcare. She coordinates healthcare systems analysis, primary care attention, and participatory governance in the Geneva headquarters, as well as in the Public Observatory. She has a PhD in traditional medicine and a master's in health economics. As you can see, we have a very select group of panelists and guests who will be with us today. Fortunately, we have now Dr. Jarvis Barbosa, who requires no introduction. Dr. Jarvis, thank you so much for being with us today. And go ahead, please. Thank you so much, Natalia. Good morning, everyone. We warmly welcome you. It is a pleasure to the Pan American Health Organization to have this valuable outreach and to gather a group of exceptional experts to reflect upon challenges tightly interlinked. First, how to overcome access barriers to healthcare services, then how to guarantee continuity and attention provision and holistic attention and quality attention. Today we celebrate a triple deployment, all very significant. First, we are beginning a series of online seminars that will allow us to exchange ideas with colleagues from many areas. Here we will seek to focus our conversation on integration of healthcare services and implementation of primary care. And second, we will present our regional report entitled Analyzing and Overcoming Access Barriers to Strengthen Primary Healthcare Attention. On said report, we present experiences in our region in analyzing access barriers and the design of policies to reduce and remove them. And third, we share results from the fourth round of the national survey on continuity of essential health services during the COVID-19 pandemic, a survey which has provided us an important input for decision making throughout the COVID-19 pandemic, and at that opportunity it provided us updated information to January 2023. This information is essential since it will help us to strengthen our actions and decisions to tackle healthcare challenges that we're facing, among them building more resilient healthcare systems that can be attained with healthcare attention for priority issues being during a crisis or a public health emergency. Access barriers to healthcare services impose one of the most significant challenges and complex challenges that we're facing today. Even before the pandemic began, we were already facing inequalities in access and intersectionality of barriers, which presupposed great obstacle to attain true equality. To provide perspective, before COVID-19, around 29.3% of the population in the Americas had unsatisfied public health needs, affecting around 295 million people. Unfortunately, with the arrival of the pandemic, those obstacles deepened, giving way to interruptions in supply as well as demand of essential healthcare services. The outcomes of surveys reveal that even 3 years after beginning the pandemic, and also with the suspension of the COVID declarations such as public health care significance worldwide, healthcare services continue facing significant interruptions, making difficult our capacity to fully recover them. Human resources are needed for healthcare, and this has played an important role during this time. Also, our report on obstacles highlight how problems related to acceptability and demand of services has deepened during these hard times. It is important to acknowledge that these barriers affect predominantly those in a situation of greater vulnerability, Afro-descendants, indigenous populations, impoverished families who live in the favelas of the great cities in the region, those who live in rural areas with access difficulties, which difficulties even further them accessing healthcare. For PAHO, primary healthcare attention is fundamental to overcome these challenges. It is truly the heart of resilient healthcare systems and universal health as a key to ensure better preparation for the next crisis, which we do not know when it will happen, how serious and which virus will be responsible, but we do know it will come. But also, PAHO is central to ensure health care equality. APS is also the road to recover lost progress during the years of the pandemic. It is important to recover continuity of essential services to revert pandemic trends in the rate of maternal and child mortality and to increase coverage of vaccination, which was also hardly hit during the pandemic, to accelerate the removal of communicable diseases such as HIV, tuberculosis, and malaria, and to expand accessing healthcare services for control and prevention of chronic disease, non-transmissible and mental health. Chronic non-communicable diseases in our region are responsible for more than 80% of disease, but 30% of these cases would be preventable and avoidable if we could have obtained access for diagnosis, screening, access to medication, and control of said diseases. Allow me now to switch to Spanish to conclude on these lessons. What?
Five priorities of this organization would be: first, to leverage the lessons learned from the pandemic, and two, to transform our health system by strengthening primary healthcare. At PAHO, we view primary healthcare as a strategic approach that addresses the needs of people where they live, at the community level. In that regard, our strategy for the expansion of primary healthcare in the 21st century is critical to address fairness in access, ensuring continuity in the provision of health services. I want to address specifically the issue of access today, which constitutes an overarching objective of primary healthcare. It will be discussed in depth in this webinar, as we report on the major barriers to access that people face in addressing their health needs. It will be important for countries to address these barriers in the design and expansion of primary healthcare at the geographical, administrative, financial, and cultural levels. Furthermore, continuity in service provision at the community level impacts immediate and future health outcomes, and if not guaranteed, it results in delayed care, excessive morbidity and mortality, and increases in waiting times for specialized care. Ensuring epidemic resilient primary health care is an area of work for our region and must be, today and in the future, one of our most important priorities. For these actions, policymakers must sustain investment in health surveillance, in primary health care, and the performance assessment of health systems. We must embrace innovation to modernize primary health care and avail of accelerated transformation of digital technology in this area. And we must go beyond the aspirational statements and translate theory into practice, implementing specific policies and strategies that directly target the challenges in assessing health services. This approach must be essential to reduce and eliminate access barriers, ensuring equitable access to health services for everyone. These are just some introductory notes, as the richness of this activity lies in the reports we are presenting today, and especially in the comments that our guest speakers will share with us next. I want to thank all the speakers that are joining us today, that will share the experience and will contribute to this proposal to discuss the barriers, strategies to overcome them, to guarantee real access for everyone in the Americas. Thank you very much to all for participating in this webinar. Your engagement and commitment to overcoming access barriers in health services are vital to improving the well-being of our communities. Together, let's continue this dialogue and take action to create more equitable and accessible health systems for all. Thank you very much and have a wonderful webinar.
Muchísimas gracias, Dr. Jarbas, por sus
Thank you
esclarecedoras
so much, Dr. Jarbas, for your opening words. And without a doubt, we will attend your call to continue on this dialogue and act on access barriers via holistic perspective and a localized for primary healthcare attention. And as I had announced at the beginning, to present outcomes of the two mentioned reports and to provide input for the discussion we will hold next, I have the honor to give way to Dr. Ernesto Vascola, Chief of the Primary Healthcare Unit. Sorry, the audio is cutting out.
Buen día. Creo que hay un problema de conexión.
Good morning. I believe there's a connection issue.
No sé si me pueden confirmar si estamos viendo la pantalla.
Can you confirm to me whether you can see my screen? Thank you so much, Natalia, and our director, for your words, for your opening words. I will hold a presentation which sets the access on access barriers and guaranteeing continuity in healthcare service provision, somehow synthesizing some results and findings from these two documents or publications that we are deploying and that we're making use of in this webinar as a way to open up a debate on the pillars that are central to us, not only in light of primary healthcare attention as a fundamental strategy to strengthen healthcare service systems, but at the same time as a pillar which guarantees compliance to the right to healthcare in our region. Next, please. Well, we have addressed matters of access as part of one of the central pillars which somehow articulate most of the mandates and products that organization has had in the last years. Without a doubt, an universal access strategy, the strategy for universal access to healthcare and universal healthcare coverage by the end of 2014 has represented a central pillar which has opened an agenda of technical cooperation throughout the region and from which many initiatives and documents and efforts have been deployed from, even regarding technical cooperation with technical and conceptual frameworks that delimit to the Pan American Health Organization and our unit in particular. I cannot stop highlighting the report from the High-Level Commission, which is one of the central elements and has recommended in our organization, obviously, among others, to strengthen healthcare systems and to guarantee the right to universal health, and setting the pillar on analyzing access to healthcare services. Obviously, as a response to this strategy and this report, we must highlight the 30/30 Pact, where one of the central pillars was related to reducing at least 30% in access barriers to healthcare systems. As we will see throughout the presentation, this continues being a structural limitation that we have in the region, but also technical documents that are very relevant have been produced, which somehow shape our very technical cooperation, such as the framework for monitoring universal healthcare access, where the pillar of access to healthcare services is practically not only an intermediate result from that monitoring framework, but also a central pillar which interpeels the analysis of healthcare policies and transformation processes of healthcare services. Another element that I would like to highlight is essential functions of public healthcare that are organized based on 4 phases of the policy cycle, the last critical and essential being comprehensive access to public healthcare interventions, and also including not only individual services, but also collective ones with an intersectorial engagement which can somehow influence on social healthcare determinants. At the same time, we have other strategies in the last years, such as the Strategy and Action Plan for Quality, the strategy for the establishment of resilient healthcare systems, and lately, for a year now, and the policy of comprehensive attention to improve healthcare conditions of the population. It is part of this journey that our director, Jarvis Barbosa, had mentioned before. We are making the most of this opportunity to highlight, we believe, 2 publications that have been key and the result of a large production of the last 2 or 3 years. The first being the publication that is related to analyzing and overcoming access barriers to strengthen primary healthcare attention. And the next one, please. It was also mentioned
que destaca los resultados de la
There is a publication mentioned that is about the 4th round of the national survey on the continuity of essential health services. And this is the 4th round because we're talking about the 4th round because we have sustained different, we have carried out different polls about the impact of the pandemic, but also about the innovations of the countries about this issue. And in this 4th round, we have also recovered and completed the analysis of the backgrounds of the pandemics and the evolution of the pandemic in our countries. I will go to the first publication, meaning the analysis of the barriers that are faced by the populations in a situation of vulnerability. It's a publication that has to do not only with an analysis of the problem, but also of different types of experiences that have in some way interfered or or challenged the trajectories of the authorities in the health sector in order to set up a dialogue and improve the conditions of access to health services. There is an initial chapter here that is structured according to the problems of the region and the main problems. And I would say not only relating to the access barriers, but also about structural problems that countries in the regions face, especially in relation to inequality and of access. And there is also a second chapter more centered on methodologies or methods of these exercises. And from chapter 3 to 6, there is a synthesis of these results in the 4 cases that we have been working on during the past years. And I'm including in this sense the cases of Colombia, Guyana, Honduras, and Peru. As you see here, the conditions were very different from each other. And there's another chapter, the final chapter of reflection about these challenges in terms of the policies for recovery and strengthening of health services centered on primary health care. And well, some of these figures were already mentioned by Dr. Jarbas. When we look at the situation in all the countries of the region, while when the conditions of human development worsen in our countries, the barriers to healthcare services go up. And this goes even beyond the performance of health services, which shows the determining factors, importance of the factors of access and poverty in our countries. But in order to make this more precise, we're talking about conditions before the pandemic. In the year 2019, we already had an estimate of 2.5 million preventable deaths, early deaths in our region that could have been prevented if there could have been an access to healthcare, quality healthcare services. And there's an analysis of 15 countries. It's a subgroup of these countries. It's almost a third part of the population that has experienced different kinds of barriers to healthcare services. And this, this means about 300 million people that do not have appropriate access. Another element of the analysis of the diversity of these cases and the analysis of the impact of these barriers has to do with recognizing the different kinds of barriers, the different characteristics. And this is something that will be present in the whole webinar, and it has been present in the two publications, and that has to do with the impact of inequality, because apart from recognizing the weight of the different barriers in different contexts, we have to point out that this is what you are seeing on the screen is a summary of all the countries analyzed. We have geographical, financial, availability, and inequality barriers. And inequality is crucial. If we eliminate the barriers that are related to the availability of resources, of health resources, we see that the peoples, the Afro-descendants, indigenous peoples, the people that live in very remote areas, etc. These are the central barriers, apart from the financial barriers and the geographical barriers. But when we try to interpret the results and provoking a dialogue of policies in order to give response to each situation, what we did in these 4 cases was to go into depth into our analysis in 4 large phases. The first one about the adaptation of each one of these studies to the reality of a certain territory. In some cases, these territories we're focused on the country as a whole, but in others on a particular region. And there was an interaction with the most important actors. And here I want to point out the crucial role, as mentioned before, of the country offices or PAHO country offices that have been a critical factor in methodology and political issues, and in the interaction with decision makers, both at national level and subnational level. The second stage had to do with a very complex work of collecting quantitative and qualitative information about, for example, polls of the population, and also the design and production and interviews with focal groups, key focal groups, including users, managers, decision makers, in order to complete an analysis that will go towards a triangulation of this information and that in some way served to articulate the analysis in a territory and an analysis of the policy processes in these territories, not only as a result of the performance of the services exclusively, but also incorporating the challenges, social challenges of these populations. And as a result of the progress made and also the backlashes during the previous 2 decades. And this allowed us to set up a dialogue with the key actors in each one of the cases analyzed. And in this framework, we start with a conceptual model that allows us to distinguish between coverage in formal terms, but not only in formal terms when we are talking about coverage of a population that is insured, that it has some kind of insurance and coverage of services. But we're talking also about cases and methodology that has also it's a model of effective coverage of Tanahashi. It's a methodology that is some years old, but it's very important. And also it includes factors such as acceptability by the population, taking into account gender, language, etc. And apart from that, apart from acceptability, also to guarantee effective contact when these are needed, when the contact is needed, so that the population can use the services when it needs them. And also when we overcome this barrier to access, we have a need to ensure the continuity of health services. And in this sense, it's very important to take into account comprehensive coverage. Once we ensure that the population has access to health services, we have to ensure also the continuity of these services throughout time and different problems. And here we see some results of the studies that we have carried out. Next one, please. Here we can distinguish between not only access barriers in the different cases, but also the main challenges in terms of inequalities, gender inequalities, wealth inequalities, financial inequalities, and we have been able to look at this from a temporal point of view, and the changes along these periods. This is key for us because if we compare the performances of the different services and we analyze some particular barriers, such as financial barriers, and we have been able to identify substantial improvements in formal access, and so the set of barriers apart from coverage is still a central challenge apart from the coverage itself. And when we have gone into depth into this analysis, we can also recognize that certain patterns that are very interesting. For example, we can see that in the cases of Colombia or Peru, the most important barriers were related to acceptability in the first place, and in the second place, accessibility, organizational accessibility. And this was also linked to guaranteeing the continuity of service. And we can see also the case of Honduras, where we are not talking about the main barriers. In the case of Honduras, the latest data we had available that were from 2019 had to do with financial access and also geographical and organizational access. And there is something that was key for us that didn't have to do necessarily with the wealth of information of the different types of barriers that allows to recognize the different challenges and showing the different factors that explain each barrier, but also the interaction between the different barriers, so that the analysis makes sense both in the relationship to the polls, but also the information that was gathered in terms of quality of service. And there are other important phenomena. For example, in the case of Colombia and Peru, in the cases of Colombia and Peru, we have been able to see transformations along time, because these services changed through reforms in the health service. In the case of Colombia and Peru, we have seen very significant reduction of financial barriers, but while the financial barriers were reduced, there were other types of barriers that became more important, as was seen in the last slide, that had to do with access, barriers that had to do with access, organizational barriers, and also the quality of the processes. In many of these cases, we can see that there is a certain formulation of policies that in some cases has allowed us to have access to coverage to a package of services, but not always in all cases. There were problems of regulations and policies that have not improved the coverage and the services, including services that have not been included in the packages for certain regions or populations. For example, in those regions where the conditions of vulnerability were higher. And well, there are recommendations of policy that are linked to certain findings. For example, the need to provide access not only through structural reforms, but also through the development of capacities and structures of governability in order to provide a better response to health services, mainly in the most vulnerable regions. But I would like to say that part of these exercises involved also the managers of these policies and the authorities. And so there should be a way to include these barriers into the discussion of policies, healthcare policies. These are the recommendations that we identified before. I would like to point out here that these barriers continue a long time. And there's also the need to go into depth in the assignation of resources and strengthening the public system, mainly in those places where we have more indigenous population or rural or remote areas. These are crucial elements because in those cases, the access to healthcare services is even more difficult. And it's not only a question of transforming healthcare systems, but also in intersectoral policies. I will comment on the results of this second publication, and it has to do with the interruption and reinitiation of these essential services. As mentioned before, in the fourth round, and we're talking about the last months of the past year, most countries still reported interruptions of healthcare services because of basic problems such as lack of financing or staff, and also linked to more structural problems such as a higher demand from the population. And here I want to show you two slides that illustrate the evolution very well in our region and how the certain barriers were increased with a certain expected behavior with the first period in 2021 and 2022 with an interruption of services and then an improvement, a substantial improvement when we are talking about specific care or the care of hospitalized patients. We are not we have not, in many cases, we have not achieved the levels pre-pandemic levels, for example, in emergency services, although there were some improvements at the end of 2021 or the beginnings of 2022, but the improvements are still not very much present. So these are very important challenges. And if we compare with the interruption of figures available because of the interruption of traceability and information services. And we're talking about the second round in the first stage of 2021 and also the third round at the end of 2021 and the fourth round the last stage of 2022. We see that in these tracing factors, there is a very significant improvement for essential services, such as, for example, vaccination, mental health, and also the diseases that are not transmittable. And we also have important issues such as care of the elderly, and we are working of senior citizens, and we're working on the recovery of these services from the PAO perspective. But there is another component in this poll that also we would also like to point out, and that has to do with the qualitative analysis of what the countries have recognized as policy response on behalf of the countries. all countries informed of at least one successful action in the case of a pandemic, to face a pandemic. And here we have the lessons learned, innovation, more innovation capacities. Almost 90% of the countries have developed initiatives and plans in order to provide continuity in essential services, and 30% of the countries have had plans or have developed plans to strengthen the resilience of healthcare services for future pandemics. And this is there's more than 70%, no, more than 40% have assigned initial additional funds with public funds apart from what existed in the healthcare services. Sometimes resources were reassigned, and this led to a strengthening of capacities during the pandemic and for future pandemics. And they are very much linked to governability structures, assignation of resources, and strengthening of the response capacity, and also vigilance and labs, and risk analysis and participation of communities. Some lessons learned linked to this study was that the interruptions in health services extended over 3 years during the pandemic, and they are persisting even after the 3 years of the pandemic. And this has to do also not only with the duration of the pandemic, but also some limitations in the resources, and also the fear of the population to use healthcare services. And so it was difficult to also to recover the demand, the level of demand after the pandemic. And there have been structural issues that have been an obstacle to the recovery of the level of these services. And we also need to analyze the lessons learned during the pandemic and the need of articulating the strengthening of of our healthcare agenda for future emergencies. And here I want to point out some general conclusions, point also the key role of primary healthcare and an integrated healthcare service, and offering not only individual services, but also promoting community health and with a multi-sectoral approach. And this is not only solved with more resources or protocols or more financing. It's very important to strengthen the management capacity, the response capacity, the institutional governability with a territorial focus. And in the second issue would be the intersectoral collaboration and the strategic planning in health, in the health sector, with different factors, different resources, and also the territorial focus as a central element that will provide the analysis and response for the reform of health services. And we also need to recognize specific needs in different population groups, to improve the quality of services and the continuance of these services. And something that will be a part of the next webinar we are organizing in this unit, that has to do with to improve the financing of appropriate health services. Next, please. Here we'll finish, I believe. I want to point out the key element. We know that in the region, many of the countries are talking about transforming their health services in a macro, with a macro approach. Other countries are setting up a special effort for certain regions or attending to the needs of more vulnerable populations. And it's important to maintain the dialogue and linking the macro strategies with a small scale, also a smaller scale in different territories. I would like to thank all the team, Natalia, etc., Coutinho, for your impressive work, not only in these two publications, but also by showing a greater capacity to measure the needs and also to improve the dialogue in these 4 countries, but in all countries of the region. Thank you, Ernesto, for this presentation. And well, this has been a very enriching presentation. We have a lot of people now connected to the chat, and I also please continue posting your questions in this exchange and dialogue that we see in this space. I also want to tell you that apart from that, these 2 presentations that Ernesto mentioned are available in the chat for your use and for the colleagues that are part of your work network. I would also like to point out one important element in Ernesto's presentation that leads to important discussions among ourselves, and that would be the experience of access barriers. It's not the same for the different parts of the population or in the different territories. So we need different approaches for different territories in order to improve these access conditions for the population. And this is a great question. And how we can make this approach, set up this approach in the different regions in order to have a differentiated access and approach. And so, well, we will now leave the floor to the the 4 analysts that I introduced at the beginning. We have prepared a number of questions for each one of the panelists that have been invited. And the idea is to have a fluid exchange, and I want to invite our colleagues to to follow this exchange through the chat and to set up a discussion among yourselves. We have an important challenge that is linked to these questions, such as the access barriers, and we have 5 minutes to answer each question. I will change to English for a few minutes in order to invite Professor Chater.
Disculpen un segundo. Miembro fundador y presidente del grupo de trabajo sobre práctica rural.
He's a founding member and part of the work group of the Wungak family.
Presented by Ernesto, and that present, the persistent inequities in rural areas and the necessity for further rural proofing of health policies. Based on that comment and that premise, I would like to pose the first question to you, which is, why is it critical to comprehend and address barriers to health services as part of a more comprehensive approach to adapting policies and services to rural needs?
Thank you very much, Natalia. And it is a great pleasure to be here. It's 1 a.m. in Australia, and I hope I make sense at this time. I am a professor of rural and remote medicine in a rural area, and I live in that area and want to give you a perspective from the front line, from rural areas. What we need in rural areas is accessible, acceptable, and affordable services. And that's very much around geography. It's the isolation and the access problems that are important. The big issue here is, however, that often that access problem is trying to be addressed with city-based solutions. In rural, we call this geographic narcissism. It's the view that rural solutions can be developed in the cities. And in fact, what we need to do is make sure that we have a rural perspective, a rural lens. You mentioned rural proofing, and the idea there is really that policies need to be made from the very start of rural areas. They need to be sensitive to the needs of those rural areas. They need to have a rural lens. It's about not only access, but it's about resource allocation. There has to be fair resource allocation into rural areas, but it also needs those areas to be able to use those resources efficiently. And when we come to the second question, I'll certainly be happy to talk a little bit more about how to make those resources work efficiently.
Dr. Shater, thank you so much. And we greatly appreciate you staying connected with us at 1 a.m. in Australia, where you are based. Thank you so very much for that. And certainly, I think one of the key important aspects of improving access conditions for communities living in rural areas is, applying these rural lenses. Why, if I may inquire, has it been so difficult, so to reduce health disparities in rural areas and apply this rural proofing approach that is being promoted, as part of WONCA and also the work of the WHO? And if I might add an additional question to that, what elements have not been adequately considered as part of this rural proofing of health policies?
Thank you. I'd start off by making a point that if you are asking the wrong questions, you can't get the right answers. So the important thing I'm going to challenge you on today is to ask the right questions. And that's looking at 4 aspects. The first is the definition of primary care, the structure of education in rural areas, the composition of the workforce, and also the funding. So let me just go through those very quickly individually. I think primary care has to be looked at as comprehensive care, particularly in rural areas. Often primary care is seen as smaller, not as good as the hospitals. It's divided often in the cities between primary care and secondary care. And that's a model that might work, and I'm not going to go into that. It might work in the cities. Sometimes it does, sometimes it doesn't. But in rural areas, primary care needs to be the proper definition of primary care, which is comprehensive first access care. And that comprehensive first access care has to do individual care, it has to do public health, it has to do hospital and emergency care, it has to do community services. And then in that is emergency medicine, maternity services, surgical services, palliative care, so many other things. So I think it needs to be, the first thing is to have a proper perspective of what the services need to be and they need to be comprehensive and able to deal with all those things. The second point I'd make is that health professional education needs to address that need. If we're going to be training rural doctors, rural community health workers, rural nurses, they need to be trained in rural areas. And that's a failing of the education system in many areas. You cannot be what you cannot see. And so you need immersive, community engaged education that allows the young students to actually learn how medicine, how nursing, how other services are done in rural areas, which is quite different from urban areas. The other part of this is to what we call grow your own. It's make sure that rural areas grow their own students into those health professionals. So you need not only comprehensive services, but you need the health professionals to train in those areas and be able to see how services can be provided in that comprehensive way, not the fragmented way that often happens in urban areas. The third point I'd like to make is around workforce. And I think the key area here is that the workforce needs to be made up of generalists, not specialists. So everyone needs to be a generalist in rural areas. So instead of having fragmented systems trying to provide specialized services, what we need to have in rural areas is for all the health specialists, all the doctors, nurses, and others to be generalists and be able to have full scope of their practice. So nurses need to work at full scope. Rural doctors need to be able to do often specialist type services. And there's often a concern about that. You know, are you doing enough of these services? There's many skills in medicine and nursing that I would call bicycle riding skills. There's skills that once you get on the bike and learn how to do it, you're quite good at it. You don't need to be doing it again and again. It's not open heart surgery that you need to be doing many cases. So we need to have these doctors, nurses with a broad range. And so that's the third thing, is to have that workforce that can provide those services. And then finally, I just, and it was touched on a little bit in one of the talks, but I think there is a need to have private-public partnerships. You can afford sometimes in the city to have private and public separate, but in the country you can't. And you need to make sure that the infrastructure that is often put in place by well-meaning governments is able to be used not only by the private sector, not only by the public sector, but also the private sector. So I think having the integration of those services. So I'll just reiterate, I think there's 4 things that I think in a very practical way can be done in rural areas for rural areas. And that's to make sure that we have the true primary healthcare, that we have the health professionals educated in that context, that they work in generalist teams, and that we have some integration between private and public services. I hope that's been useful. Thank you.
Super useful, Dr. Shater. Thank you so much for your valuable insights and all these, 4 operational and practical recommendations for, applying the rural lenses, to the primary healthcare approach. If you allow me, I'm just going to paraphrase for the benefits of the participants who, by the way, are actively exchanging on the chat based on your comments as well. This comprehensive definition of primary healthcare, education and retaining of human resources for health within their home context and territory, the different hats that human resources for health health workforce need to wear, and the different, specialties and activities that they need to conduct in rural areas, and private and public partnerships. Thank you so very much, Dr. Shater, for those valuable insights, and we look forward to continuing on this discussion and collaboration. Estimados colegas, voy a cambiar nuevamente al español para escuchar el punto de
Dear
vista.
colleagues, I am now switching again to Spanish to hear Dr. Cunningham's perspective, who is also with us. Dr. Cunningham, welcome again. In order to frame our questions that we have for you, I would like to frame that in many researches on access barriers that were mentioned during the presentation, and that are also present the many sources of evidence on these topics. This highlights the persistent inequality which especially affects indigenous communities and which also relates to the need to deepen intercultural skills of the healthcare staff and the capacity of adaptation to the healthcare system to the needs and preferences of our indigenous peoples. Based on this premise, I would like to pose a first question for your consideration, which is how can we adequately train healthcare staff and to adjust service provision models in the region so that they have cultural skills that are adequate? Dr. Cunningham, if in your question you could also tackle any experience that is valuable in the region with regards to this issue, that is welcome. Thank you so much, and go ahead. Thank you so much, Natalia. Greetings from my people, the Misking people from Nicaragua. I studied medicine many years ago, and the first that when I went back to my communities to work, after me being trained in university, we had that really, I hadn't really learned much in university, according to what I found in the communities. I did not know anything about indigenous diseases. I did not know much about the worldview beyond what I had heard from my grandparents. And really, I did not know the healthcare network of indigenous peoples, which means that in training, we require training staff that is able to participate in this informed and effective exchange for building policies, programs, and projects. And we also need to have skills in attention with cultural pertinence and to know about the rights of indigenous peoples, as well as knowledge on the many explanatory models of the health disease process, because every people has its own explanatory model. The biomedical healthcare staff, therefore, should understand the concept of health disease that we indigenous peoples have, including, as I said, the worldview, the protection and promotion of health systems, the therapeutics, the stakeholders, and rehabilitation systems or recovery systems. However, when speaking of the staff, we must speak of two kinds. The indigenous healthcare staff in our region, we are just beginning to resolve with training of our own staff of indigenous health via our universities of health, which are training intercultural physicians, intercultural nurses. So it is necessary to propitiate training and skills of indigenous stakeholders, traditional physicians. We have a network of traditional physicians or doctors. For example, for COVID, traditional doctors, Mayagnas, they gathered and they themselves began to seek the many herbs. We need to train authorities and facilitators of the system, indigenous in basic elements, for instance, in Western epidemiology, how that complements with the traditional system and management of reference and counter-reference, the networks of contact. Also, we need to achieve for this staff to have real access to the many levels of universities. Regarding the non-indigenous staff, it is necessary to promote training and skills to operate in intercultural situations. Apart from understanding the system and practices, for instance, considering gender relationships, how they affect behaviors regarding health. And in that sense, the efforts from the Intercultural Indigenous University with the Pan American Health Organization has been fundamental for the exchange in the provision of courses, postgraduate courses, or master's programs in intercultural health, which really allows to combine medical anthropology, healthcare sociology, interculturality with the rights, which ensures this intercultural perspective. PAHO can play an important role establishing international spaces where leadership, indigenous leadership, and leadership from the ministries of health really deeply tackle these topics, and they can really strengthen the exchange and the building of indigenous researchers and so on. Dr. Cunningham, thank you so much for your intervention. Moving on to the next question, which has to do specifically with have been difficulties to implement this intercultural engagement in order to engage access barriers to healthcare services that indigenous communities face. Concretely, Dr. Cunningham, is which are those aspects which have not been considered in the design of policies that relate to service provisions? Thank you so much, Natalia. I would say there are three main areas for access to health care, participation of indigenous peoples in the design of public healthcare policies, and to really work seriously in creating intercultural healthcare systems for indigenous peoples. Access to healthcare services not only means that we can access healthcare providers, but that these should resolve geographical access, for instance, which has been mentioned often, organizational wise, economic wise, cultural wise, and transportation wise. The lack of continuity in the many levels of attention with cultural pertinence, although there is cultural permanence at the primary level, if there is no such thing at the other levels, it will be broken, the possibility of access. And obviously, administrative and management barriers. There are basic things such as dignity in treatment, the touch, the warmth, the language, spatial distribution of furniture, and in healthcare units, the schedule for attention, culturally adequate nutrition, and the approachness of the therapist and prior therapeutics. Uh, Often communities are rejected following their journey of access to health first through their traditional doctors. So how to do away with those shortcomings? What are the halfway houses, transportation? Regarding building intercultural models of healthcare, there is a lacking of effective means and full access to traditional medicines. I believe that with COVID, some ministries of health began acknowledging the importance of this. They're still lacking coordination and connection between the indigenous system and the biomedical. One is subordinate to the other, really, in practice. The limited systems and resources for exchanging and building collectively to move from one level to the other. And the scarce training has already been mentioned. And regarding participation, there's an absence of mechanisms for indigenous participation. Much has been said of governability. I believe Dr. Bascolo identified this as one of the factors. However, usually governance in healthcare services leave behind all the governance expertise that is traditional and indigenous. Therefore, there is a need to build governance and management where the system, the traditional governance system really is a part of, and for this we have the issue of informed and effective exchange for building programs, projects, and policies, and so on. Thank you so much for your input throughout your professional journey that is pretty renowned in the region. Thank you so much for bringing this to our attention regarding intersectionality and access barriers that indigenous populations experience and which are deepened on the many issues that this population is facing, and also highlighting this issue of active participation of indigenous peoples, both as providers of the very healthcare services in their training, but also in this traditional governance system. We would like to consider also to become more effective in these processes of participation on part of the indigenous communities. Thank you so much, Dr. Mirna, for these inputs. And I'd also like to take the chance to salute our 800 or so participants that are currently in our Zoom room and who are following this very rich exchange via the chat with many questions and remarks. Throughout the many interventions, we hope to be able to have a space by the end of our panelists' presentations to answer or tackle some of the questions that you are posing via the chat. Thank you so much for continuing to be online, to continue participating actively in this seminar. Now I will give way to our questions to Sergio Minue. Welcome, Sergio, once again. And in order to frame what we have prepared for you, I would like to highlight the issues that both Mr. Shader and Dr. Cunningham have mentioned, which are related to supply of healthcare services and with the models of provision of services in the framework of integrated healthcare networks. Also, the outcomes proposed by Ernesto on the fourth round of the survey of continuity, which continue highlighting this issue that the countries in the region are facing in order to guarantee healthcare continuity in provision and supply of services, even after 3 years having started the pandemic, the COVID-19 pandemic. In that sense, we would like to ask you what lessons we have learned from the COVID-19 pandemic on challenges to guarantee models of attention which are comprehensive and which guarantee continuity of healthcare services. Thank you so much, Natalia, and especially for inviting me to such interesting webinar from which I'm learning so much. First, I believe that if we want to learn lessons, we will have to assess, first of all, and in that sense, I believe that what is lacking still is to develop rigorous assessments on what has happened during the pandemic. The World Health Organization was a pioneer on these matters with an independent panel precisely to perform assessment, but there are many territories which we continue having a lack of knowledge on what happened. For instance, my country, Spain, we're still assessing on what happened during the pandemic. What is clear from the report of the independent panel itself is that it is pretty evident that healthcare systems were not prepared for a challenge of the scope, and the reason, among others, but I believe that fundamentally it relates to the fact that the answer to the previous crisis, which was the economic crisis from 2008, this was a crisis of reduction precisely of the need to strengthen the public systems. There was a reduction in public expenditure and healthcare investment, especially in the domain of primary healthcare attention and public health. And in that sense, the 30-30-30 document made it more necessary than ever on attempts to monitor on part of the Pan American Health Organization on which measure we are approaching that 6% of public expenditure in healthcare, or that 30% of expenditure in APS within public healthcare expenditure, I believe is essential. A second important element, the impact of the pandemic of course, was terrible in human lives and infections by SARS-CoV-2, especially in death, but we need to be careful because mortality is actually greater, both in analyses that were performed in Europe, the US and England, the UK, and of course, also in Latin America. Second, economics of around 27, 28 million people. We are speaking of basically triple or fourth times the deaths for COVID-19, which have causes which are not related to infection. So what can they be? Obviously, there are structural elements such as, but the main element is precisely the disruption of the healthcare system, and in that sense, the interruption of essential services, because probably the implementation of the model of response to the pandemic was one which perhaps we could not conceive another at that point, since we did not know the information that we now have, but that was based on a model centered on a hospital in the absence of an intensive care unit, and in the segmentation between problems that are susceptible to be attended upon suspicion of COVID-19 or another kind of issue. And for that kind of issues, the alternative was to defer them, to delay them. And in that sense, the consequences of this model, I believe, are threefold: interruption of essential services, such as presented by Dr. Vascolo, which I believe is very evident on their consequences, and a lack of coordination between healthcare services and social services that are very important in many countries, and within the healthcare service in the first level and other second or third level. And the third element that I would like to highlight is the issue of the problem for continuity of attention, regular attention by the very professionals, that has deteriorated both because of the issue of segmenting between respiratory and non-respiratory issues, and also for the fact of segmenting also between virtual consults and in-person ones, when also during this period of time in the pandemic, the evidence that we have on the fact that regular contact with the professionals themselves is of benefit to community health. It has been shown during this period precisely. The Sandvik research in the Norwegian population as a whole shows that more than 15 with the same primary head care physician and primary contingent reduces mortality in 30%. So the question would be, what intervention in healthcare reduces mortality in 30%? And on the flip side, the other interventions where this evidence has been obtained in primary strong health with obtain better results. And secondly, that the continuity with the provider, regular healthcare diminishes mortality, continues being without a priority for a greater part of countries. And it would end up just by pointing out the huge challenge that we had in human resources. Both Dr. Mirna as well as Dr. Shader have also commented on this. I believe there are two significant challenges. First, what will we do with the non-attended areas worldwide? And second, what will we do with a huge burnout in professionals throughout the world as a consequence of the pandemic? Thank you so much.
Sí, Sergio, muchísimas gracias. Y,
Very well, Sergio. Thank you very much. And yes, of course, the continuity of service is one of the main problems after the pandemic. And so what innovations could be necessary to reduce times of wait the waiting periods for healthcare? Well, I believe that the problem of the waiting time is not a local problem, and it's not only a problem at the higher level. We have to look at it at all levels, because the first level has a very, very important effect on the second and third level. So the analysis of demand is a problem also because the increase of demand is really huge for these main reasons. We have, for first place, the increase of the elderly population. Senior citizens are increasing. I mean, and then we have the non-transmittable diseases, and then we have the sanitation technology, that the health technology that has to intervene in a greater measure. So we have the law of inverse treatment or inverse care, And there is also the analysis of barriers, as were mentioned here. But there are many people that go to health services because they don't need a healthcare answer. The problem is not that we always need we don't always need pharmacological interventions or medical interventions. And this is a problem we can face with a greater cooperation among us at world level. But there is also the question about what we can do first at the first level and also as the non-hospital care. When we prepared the document for the Astana Declaration with Professor Asianes, who lives in London, he said he had a 3-month list of people that need a GP, a general practitioner, attention. And in Spain, it's 3 weeks. This means that people feel abandoned by the professionals. The professionals want to stop taking care of their patients because they have a huge load of patients. So I believe that the problems have to be improved by an enlargement of the first level of care. And Latin America has the same problems as Europe in that sense. And before, for the physicians used to take care of everything, but there are treatments that can be provided by nurses also, especially at the first level. And artificial intelligence could help a lot, for example, with bureaucracy, because the bureaucracy is great at the level, at the first level of care. And regarding hospitals, there is a report that is very interesting by Professor Van Gieniken, and that is a policy brief for MS Europe. And here it says that we should measure the level of hospitalization need. And there's also the Velcro effect in some countries. The specialists in hospitals retain patients that no longer need specialized care. And so we have no more space for those who need specialized care. And there is also, the increase of productivity is another need in all countries. And the improvement of quality is also very important because we have to see what the first level professionals are doing and what the specialists are doing. And apart from political commitments such as guarantees, etc., we need also to face the burnout that many professionals, care professionals, are experiencing. Thank you very much for your reflections about these challenges and the problems that are faced by the health care systems in the region, and the waiting lists and the times. These two issues are very important and have to do with the human resources in health and also the burnout that is part of the COVID-19 pandemic. And these key interventions that you talk about, continuity, to have a primary physician, healthcare. So thank you very much for your comments. I would like to invite Dr. Deepa Ryan to be part of his conversation.
Health systems and policies, you have been actively active in generating research and providing information for decision making and offering recommendations on improving health systems and addressing access challenges, especially from the perspective of comprehensive primary health care. Based on all of this experience that you have been accumulating, we would like to ask you, how can health system reforms focused on primary healthcare impact the reduction of barriers and improvement of access to health services?
Thanks, Natalia. Yes, at the moment we're doing a global evidence review, actually, with the observatory, the European Observatory and WHO, looking at the impact of primary healthcare on a variety of health system goals, such as access and equity and quality, etc. So the first thing I'd like to say is that in general, the implementation of primary healthcare policy definitely can have positive and equitable impacts on the health of people in all income contexts. But I say very purposefully, I say can have, because it really depends on what those policies are. And it's really about primary healthcare being comprehensive, the way Dr. Chatter nicely laid out in his intervention. Comprehensive and equity focused. I think those are really the key characteristics. And so it can benefit, this is what many of the studies show, it can benefit socially vulnerable groups and the overall population. And that finding holds even for fragmented and weak health systems. So even in contexts and studies that have been done in really fragile and conflict affected contexts. And this is really because primary healthcare has a proximity. It has an inherent proximity to people and communities, and that really enables a better outreach and understanding of their population, which benefits those groups, with especially population groups with poorer outcomes. Now, in our literature-based analysis, we found a number of specific drivers behind primary healthcare's impact on improving access and improving equity. So I'm going to lay out 5 of these drivers, and one of them is targeted policies for really strengthening that first contact level of care. So what we would call the primary care level within primary healthcare, because that's where the interface is between communities and health systems. And secondly, it's about multidisciplinary teams. So a big driver that we found in the literature was the existence and the good functionality of multidisciplinary teams, really benefiting vulnerable groups, really benefiting those who have less access to care. And this is largely because multidisciplinary teams have a remit that goes beyond curative care, goes beyond that biomedical model of care, as we heard from Dr. Mirna. It includes team members who are responsible for public health, responsible for community work, for example. And so the third strategy or driver that we found in the literature is community health workers. The community health workers, and there's now a lot of literature on them, really improves access to care and improves health equity. And the fourth strategy or driver was that we found is something that we call empanelment. So it's assigning responsibility to a provider team or a provider, an institution, for a defined population. So it's about feeling responsibility for a population, also vulnerable groups, before they're sick. So whether they're sick or not, we have responsible for their health. And then the fifth strategy or driver is having explicit coverage with public funding for vulnerable groups. And I'll get into that maybe more into the second question, which is more on financial barriers of access. But I'd like to just sort of flesh out a little bit these first 4 issues. And the first one, as I said, is about primary care, or that first contact level of care, being an organizing principle for delivering services. And that really does promote equity, and it promotes access. And the strongest evidence we have really comes from that organizing principle of primary care. And it's been associated with reduced socioeconomic inequality, improved continuity of care, especially for lower socioeconomic status populations, better health outcomes. And this was from a systematic review. It also, and this is, of course, it's measured along several different kinds of indicators, but among them, unnecessary hospitalizations, for example. And strong, when we have strong primary care, this also promotes a more equitable distribution of resources, including the workforce. We've heard from Sergio and from others about the health workforce crisis. And in fact, in Spain, the country does resource allocation weighted by age, rurality, disease prevalence. So effectively improving equity in primary care provision by sending resources where there's greater need. The second strategy that I mentioned, multidisciplinary teams, this is really, really important. And I think this is something where we have a growing body of evidence on. You know, a multidisciplinary team offers a broad skill set. Usually they tend to be close to communities, sort of decentralized. And we have a lot of really good studies coming from family health programs implemented, for example, in Brazil, in the PAHO region, from Portugal, from Turkey, and it really presents strong evidence for you know, the added value of multidisciplinary teams, and especially when combined with empanelment, with community engagement, and integration of primary care and public health to really overcome the inherent fragmentation that we have in a lot of health systems, especially felt by underserved communities. And these kinds of programs have demonstrated, you know, improved availability and access to services and reduction in health disparities. And it's the decentralized provider structures in these programs that are really crucial to ensuring that communities can, you know, that can have tailored policies and the policies that are really tailored to the local context. You know, the issue with multidisciplinary teams, as I said earlier, is that you have a range of skills and a range of backgrounds and a range of paradigms that the different team members come from, which means that you dilute a bit the biomedical paradigm that tends to dominate in health systems worldwide. But with multidisciplinary team, you bring in, along with the doctor and the nurse, you bring in, you know, physiotherapists, community health workers, you bring in a lot of other skills and paradigms that are difficult to bring together. And in practice, it's not so easy to work together coming from different, you know, different angles and different trainings. But by investing in making it work, you are able to better address community needs and better address their access to care by understanding what those barriers of access are. And even in high income countries like the US, like in Australia, you know, innovative models of care that incorporate these team-based approaches that, you know, for example, provide services beyond regular working hours, have been associated with higher levels of appropriate care and acceptable care. So two big dimensions of access. Then the third driver that I mentioned was community health workers. And I think this is a really, really key. We saw in COVID-19 how important community health workers were in many countries. So it's really important that they are adequately remunerated and supported in the system and have an actual and have a, you know, somewhat more formal role in the system. You know, and they are able to bridge health services with underserved population and have, you know, facilitate insight into implementation of policies. Also, they're able to identify where programs fail to work for disadvantaged social groups, and are able to more easily identify, you know, which people experience social and geographic isolation and marginalization and why. And a great example are Brazil's indigenous health agents, for example, who also are able to incorporate traditional medicine practices that align with cultural beliefs surrounding health and disease. I think, you know, we had heard very nicely from Mirna how important that is to improve acceptability of services as a dimension of access. And in many places, community health workers also have a sort of advocacy and activist role and help and challenge some of those status quos of inequities and problems with access and call for health systems reform. So I think this is, and you know, in the literature, we found this to be one of the key reasons why primary health care has a positive impact on access and equity. And then I'd like to finally discuss empanelment, and this is about assigning responsibility for a certain population to a provider team or a provider, and it's you know, making empanelment work is a dynamic and iterative process. It involves identifying and allocating populations to either a facility or a care team. And the idea is that by assigning a population to people, to providers, they have responsibility to know and understand their assigned population, to be proactive. So that's an important word here. It's proactive. So it's about public health, not only curative care. So really proactively deliver coordinated primary care. And so basically what it does, it fosters the care team to be to do outreach, to be proactive, to do outreach based and understand population need, regardless of if people are sick or not. And it really fosters that deeper understanding of patients, of their families, their community environment, fostering a more holistic approach. And it's been shown in a number of studies to improve patient satisfaction. Recently, there were a number of studies came out from Turkey on their family health program, and it really showed that patient satisfaction had increased quite a bit over a 7-year period, linked to the fact that they had one provider team assigned to the patient. Other studies have shown, for example, that low-income urban population have higher utilization rates when there is an empanelment system in place. So this is really a strategy that really pushes primary healthcare to improve equity and to reduce access barriers. And then the fifth one is, and I'll get into that maybe in a few minutes, is really it's about public funding, and it's about having coverage for vulnerable groups. Thank you.
Thank you so much, Deepa, for sharing with us, all the insights and evidence, that you have been collected as part of your work with the WHO and the observatory, and these 5 key drivers of PHC and how they are helpful in addressing different dimensions of accessibility. Ultimately, following up on that last component of increasing financing and addressing coverage for vulnerable populations, I wanted to talk about financial accessibility barriers as part of the next question, which has been, one of the focuses of the work and research, that has been implemented as part of the work in the WHO and the observatory. And the question is, what is the impact of these financial barriers on health services in low-income communities? And what are the best policy practices identified in other regions?
Okay. Yes, thanks, Natalia. Yes. So basically, really one of the best things you can do to reduce financial barriers to access is to provide more public funding for health. What is also, really key is explicit coverage for vulnerable groups that really improves equity, improves access. So these financing models that are really equity informed, that prioritize spending from the public purse and require payment based on ability to pay. And they distribute the cost burdens and the benefits according to need. So these are what is associated with better outcomes and greater equity. And the literature really points to equity and access improvements through publicly financed coverage in all 3 dimensions of the so-called universal health coverage cube. So service coverage, so basically having a broad range of essential basic first level services that are really covered, population coverage, so to cover as many, ideally all of your population, or as many as you can, and cost coverage. Because when a publicly financed health system really covers the whole population, including people in vulnerable situations, then you have improved access and equity. And what that means in practice, for example, is basing entitlement on physical residence, for example, instead of legal residence or affiliation to a scheme or payment of contributions. So you want to de-link entitlement to contributions, for example. Entitlement should be linked to need, to your health need. So, and you have a great example also from your region in Peru, for example, about 10 years ago, when the government declared that all indigenous people living in the Amazonian region are officially recognized to be living in extreme poverty. then they were automatically included in the health insurance inclusive health insurance program, which really resulted in thousands of people gaining access to services free of charge. But as Ernesto pointed out, in Peru and Colombia, there's been a lot of reductions in financial barriers to access, but it's really usually not enough. Looking at financial barriers in a unidimensional way is not going to address the overall access issue. It's one important issue, but it needs to be addressed together with all of the other barriers to access. Also, because lifting financial barriers to access can sometimes have unintended consequences, and this is what we found in our evidence review, that that sometimes reduce or policies that aim to, for example, reduce out-of-pocket payments may have contradictory consequences, and I'll explain a little bit more about that in a bit. But before that, I want to make the point that primary healthcare reforms and interventions do have immense potential to reduce financial hardships. I want to lay that out very clearly, but again, the devil is in the details. So it's really about what those policies and reforms are and how they're implemented. And so a key component of the PHC approach should really be the explicit provision of a broad health service package that really covers essential health services, including medicines and public health interventions. And especially at the primary care level, we see outpatient care treatments contributing significantly to financial hardship, and out-of-pocket spending on over-the-counter medicines, on outpatient medicines have been shown to be a major driver of financial hardship. And many of those are really medicines prescribed at primary care level. And in Europe, we have the number of 38% of out-of-pocket payments in a study that came out this year spent on outpatient medicines in households with catastrophic health spending. But we see this beyond Europe as well. We know that poorer households face more financial hardship when seeking care, irrespective of other factors of care settings, specific conditions. And we know that even after controlling for many other factors, things like unemployment, illiteracy, older age, female-headed households, they're all associated with lower financial protection. So really what that underscores is that we need to embrace fully the PHC approach and implement implement the approach in a very comprehensive way, and also monitor and evaluate very closely what the effects are of some of our policies. I'd like to just say that because with financial hardship and financial barriers to access, there are sometimes mixed results in the literature, and I'd like to just point to maybe one example, if I have time, maybe two, but I see that we are
running short of the time. We have
okay.
6 minutes left of finalizing the webinar. Thank you so much.
Okay, so I'll just do one quick example just to make my point. But this is an example from Georgia in the Caucasus. And basically, to make a very long story short, the universal health care program there had increased the share of the population with publicly financed health coverage from 20 to 90% in a sort of 6-year period. So it did reduce unmet need and increased health service utilization, but it didn't. So you had but the service coverage aspect wasn't sufficient out of the 3 types of coverage. So it didn't cover medicines sufficiently. And so what happened was that with the population coverage expanding, more people started to use services. However, they started to use more and more services without the medicines component being covered, and with unregulated medicines prices, households ended up facing catastrophic health spending in primary care, and so out-of-pocket payments and financial hardship actually went up. So this is just an example to say that you can't look at financial barriers of access in a unidimensional way. It needs to be combined with other policy approaches to strengthen primary healthcare in order to reduce access in general for the population. Thank you very much.
Thank you so much, Deepa. It's a lot of information. We know the challenge of presenting all of that in 5 minutes allocated for the webinar. So we really appreciate all of your insights and knowledge on these aspects of implementing PHC. We have 5 minutes left for finalizing the webinar. Voy a estar cambiando ahorita a español para la última parte. El chat ha estado bastante activo.
I will change into Spanish. The chat has been very active with several comments and questions. We won't be able to answer all the questions in the chat, but we would like to provide 2 minutes to final minutes to each one of our panelists for a final reflection on the whole thematic and the discussion we have had during their interventions and in the chat. In the cases of Chater, Dr. Shater has to do with telemedicine and the difficulties of adapting it to the Latin American context. So your experiences in those issues in Australia would be very important for Dr. Birna. How are you making progress with interdisciplinary teams and the role of universities in the case of indigenous populations? In with the case of Sergio, what's the result of the APS models to improve access? And also colleagues and panelists, any final observations, please, would be very much appreciated. Dr. Sheeter, you should start with your intervention first, please.
Thanks, and thanks for your question around telemedicine. I think the issue around telemedicine is exactly as Dr. Cunningham was saying about the issue of having some local control and local understanding, that if you have a telemedicine service that comes in and it doesn't understand the local context, the solution will be wrong. And so it's very important to have local teams. Deepa's comment about multidisciplinary teams is so important, having them empaneled to look after that population, but also enabled to look after that population. And telemedicine can support those teams to provide a better service. I think sometimes the idea of having someone dial in from outside to actually fix the patient is misguided. What they need to do is help the local team to work with the patient and to come up with the local solution that's culturally and rurally appropriate. Thank you.
Thank you so much, Dr. Shater. Le paso la palabra a la doctora Mirna Cunningham. Adelante, doctora.
Thank you, Dr. Shater. Now, Dr. Mirna, well, I believe that to go towards a territorial approach will improve the multi-sectoral team's composition in the health model for the autonomous regions. We have territorial offices, and so together with cultural services. So we work together between the cultural teams and the medical teams for primary care. I believe that this is a first step. And the second step that we should point out, it's the role of the universities. And this is not only for indigenous universities, but also for the non-indigenous. There should be a break between how we designed the supply of health services up to now, in order to now starting to incorporating the human factor. And this has to do with what Dr. Deepa said. We have to talk about financing. When we talk about financing of health services, means also that we have to value the contribution of the rural communities, the rural peoples, their herbs, their therapies, their experts. All this has value, and it's important when we analyze the financing. And we should conclude. I should conclude with the issue of reinforcing the need of this, the need of reinforcing this dialogue in order to reinforce primary healthcare. Thank you, Dr. Mirna and Dr. Sergio.
Ahora, ¿me escuchan?
Can you hear me?
Sí, perfecto. Con respecto al modelo de APS, yo creo que
Regarding the APC model, I believe the
think that
document both the vision for APS for the 21st century, as especially
for
the relational framework, which fortunately is already translated to Spanish. I believe it establishes pretty well, which is a frame of reference under which basically any healthcare system can be comfortable with. And I mean the three dimensions of empowerment and determination on determinants and services of health under the comprehensive networks model, with primary healthcare attention strengthened to the public healthcare service. In that sense, I also believe that facing the future, probably a uniform and homogeneous model for all healthcare systems is possible. I believe a reason has been commented by Dr. Mirna, and this is that every specific territory probably needs an adequate model to that territory. And I'm saying this because, for example, regarding the community concept, it is true that at the level of a territory that is rural or a small city, it can be very well limited to that community, but in current societies where especially adolescents, unfortunately the audio is cutting out, they make up virtual communities, perhaps with individuals from different countries. I believe this requires a reflection with regards to the community conception and two elements to finish, which I believe important, which has been very much commented by other of my colleagues. And this is the issue of the panel for the need for stability. There was a question regarding which would be the ideal population to designate a first level attention device to a center, and this is quite variable as there are countries with 5,000 people, perhaps by profession, and I mean healthcare professional. The most common one are medicine and nursing, and the European countries were trying to reduce this to 2,000, depending on the makeup of the team. If it's a minor, it can be perfectly tended to by medicine, nursing, and the like. We can tend to populations of 5,000 without any issues. And just to finish, insisting on the importance of establishing continued relationships in time that are regular, because this builds trust, and this is the best way to establish links among healthcare professionals and the populations. Thank you so much. And to you, thank you so much, Sergio. Dr. Rajan, go ahead, please.
Yes, thanks, Natalia. I think my final comment is just to say that I think in line with, well, Ernesto's presentation and what a lot of the panelists have said, I think we need to look at access barriers as something that is complex and multifactorial, and that can't be, addressed in a sort of unilateral way. It's like all things health systems. Health systems is complex, and we need to invest in working with our policymakers and to address it with several policies and to strengthen really the primary healthcare and health systems in a more systemic way. What we really saw in the literature in our global review in the end was that the greatest impact can be seen when there is long-term commitment to reform, with long-term policy commitment, with an intention and a great commitment to learn, also to learn from mistakes, and to try and test, monitor and evaluate, and if needed, adapt policies to the local context and adapt financing mechanisms to then incentivize those policies to the local concept. So it really requires that longer term vision and persistence and continuity, and you need some champions who will always be making the case for investment in primary healthcare in the background, while the technicians and the people are trying and testing and trying to make it work on the ground. Thank you.
Thank you so much, Ipa. Thank you so very much. Y también muchísimas gracias a los y las participantes que siguen conectados con nosotros a pesar
Thank you so much to all our participants and to Deepa. who are still on the line with us.
Solamente recordarles que la grabación del evento, al igual que los reportes que se han presentado,
In spite of this delay we've had and the WebPoint presentation and materials will be distributed, will be made available shortly on the website, which is dedicated to the seminar. I would like to give way once again to our colleague Ernesto Bascolo from the Primary Care Unit and Comprehensive Provision of Services. Ernesto, go ahead.
Gracias, Natalia.
Thank you so much,
Felicitaciones.
Natalia, and congratulations to all.
Para mí un webinar sumamente rico, muy interesante.
This has been, to
Creo que
me,
mejoramos con el tiempo.
a highly
La verdad
enriching
que
webinar and very
quiero
interesting.
agradecer
Actually,
especialmente a todo
I
el
would like to
equipo
especially
que ha
thank
hecho posible esta
to the whole
producción
team which has made
y
this
estos diálogos.
production and this exchange
Dr.
possible.
Chater,
Dr.
como
Shader,
siempre,
Deepa, as
muchísimas
always,
gracias.
thank you so
Sergio,
much.
impresionante.
Sergio,
También Mirna,
impressive. Also,
son
Myrna,
todos colegas que realmente
you are all
nosotros
colleagues
admiramos y
that we
apreciamos.
really admire
Y la verdad
and
que
learn from.
no, digamos,
And
supera
really,
compartir
this overcomes sharing knowledge that you have
logra
because
construir un diálogo,
you're able to build an
entre ellos,
exchange
un diálogo con la audiencia. Hoy teníamos
with the
el año
audience.
pasado alrededor de 1000 participantes
Around 1,000
de la
participants have
Comisión de EPS de todo
connected
el
today,
país,
and this
autoridades de
entails
salud,
all of
de
PAHO
ministerios de
offices throughout
muchísimos
the
países de la
country,
región, universidades,
authorities from
cientos
ministries
de
and many
representantes
other
públicos. Yo
institutions in the
quiero
world and universities as well. This has been very impressive.
y
So I
la
would
verdad
like
que
to
uno se queda con las ganas
issue my
que uno
gratitude. And the good
necesita
thing is that
que la fiesta continúa, que el 25 de
when
agosto
we
vamos a
have
seguir
a
con
good
este webinar.
measure, we need to announce that we will
Seguramente
continue
después
this with the following
de
webinar on
financiamiento
August
público,
25th,
renta, atención
which
a
will be
víctimas de
articulating
cáncer,
discussion on
así que
funding,
esperamos contar con ustedes.
public
La verdad,
funding,
es innumerable la cantidad de
and
gente que ha
primary health
participado
care attention.
haciendo comentarios, preguntas en el chat. Yo creo que la riqueza
So we hope to
de este
have
espacio de participación es cada vez
your
mayor.
attendance as
Esperamos
this
hacer una
space of
memoria
participation is
sobre
greater
este
every time.
próximo
We will
periodo
issue
de
some memos of this
gobierno. Se lo
webinar
vamos a
as I
mandar
see this is being
también
requested
por
for. So we will
escrito
be
en el chat
sending
para que
this out.
puedan
And also,
comentar a todos los
this was
participantes
shared via the chat, but
las
we
dos
will also
publicaciones,
be
los dos
sending
lanzamientos
to all our
hemos
participants
mencionado inicialmente. Así que muchísimas gracias
the two
perdónenme
publications,
los primeros 5 o 6
the
minutos de
two
retraso, es por
deployments,
eso que nos
and we
tomamos
have several minutes
estos 8
delay,
minutos
which is why
adicionales.
we're
Gracias,
taking these 8
colegas.
additional
Abrazo.
minutes from your time. Thank you, colleagues. Thank you so much, Ernesto, for your participation from this webinar. We hope you have a happy rest of your day, and we'll see each other at this next webinar in our series. Thank you so much.